Welcome, everybody. My name is Carolyn Dubé. I am the Executive Director with Fertility Matters Canada, and I'm thrilled today to see so many of you joining us live for this conversation, an incredibly important and really emotional and frustrating topic and experience for so many people within the fertility community and for those who have been or are on fertility journeys and then their path to parenthood, which is implantation failure. And I'm thrilled today not only to be joined by Dr. Sony Sierra, who is a reproductive endocrinologist or a fertility specialist, a fertility doctor at TRIO Fertility, and also with Evolve Egg Freezing in Toronto, a good friend of FMC, a good friend of mine, and someone I just love learning from, and I know you will too, but also for the support of this webinar and our friends over at First Response who have been working to support us in educating so many people across the country over the past several years. So huge shout out to First Response for their participation and support of events, this event today and other events that we have done in the past. So Dr. Sierra, thank you so much for being here. I am really, really excited to have this conversation. And based on the number of people, we had over 100 people register for this event. So poignant. And I think that number of registrants really tells us that people are really interested in getting this information. And so I'm excited for them to learn from you today.
Sure. Thank you for having me. It's always nice to be here, and thank you again for all the important work Fertility Matters does.
Oh my gosh, of course. And just for anybody who is live on the call today, just know that you are welcome to ask questions directly in the chat. We will try to get to some of those questions as the event or as the webinar moves through. So let's start with, we're going right back to basics, I think. Dr. Sierra, let's talk about what implantation failure is. From a medical standpoint, what is it?
So classically, recurrent implantation or implantation failure is defined typically as the failure to achieve a clinical pregnancy after the transfer of a healthy embryo. And that healthy embryo could be genetically screened or not. Recurrent implantation failure is that event happening on a recurrent basis. Usually we don't consider that diagnosis unless you failed 3 or more untested embryo transfers. However, if you fail 2 euploid or good quality embryos, we start to consider this concept of recurrent implantation failure. But one of the things that I think is important to understand in defining or talking about it's not a single event. Implantation is sort of a cascade of events that's set off by an embryo being placed in the uterine lining. So it's hard to even use the term accurately, implantation failure, because we're not sure what is failing in that case, embryo lining or the actual implantation process.
Wow. And so I think that this is, it's so close to a lot of people's hearts. It's something that I had experienced. In fact, I experienced it 3 times over the course of my fertility treatment. And many patients are left wondering why this didn't work. So after a failed cycle, what are the most common reasons why something or why implantation doesn't happen?
Right. I think it's a cascade of events. So it's really hard when you say why it didn't happen because it could be a multitude of problems. And the reality is that our science, our investigation, what's published so far hasn't told us exactly what the problem is. It could be the embryo. So if an embryo is good quality or not, if it's capable of making an ongoing pregnancy. So there could be an issue with the embryo. And that's why so many times people are using tools like genetic screening, because when you're defining an embryo as euploid, you're taking away the main reason why an embryo won't implant is if it's genetically abnormal. But having a euploid embryo doesn't equal a baby 100%. There are still hundreds and thousands and millions of cell divisions that have to take place after a euploid embryo is placed. There are things that we don't quite understand, but we know can be a factor. Things like mosaicism in the embryo, epigenetic phenomena. So there are embryo issues that are involved with implantation failure. And then there's what we call opposition, the next phase in implantation, when an embryo has to come into contact or close contact with the lining. And there we could have structural things like people who have polyps or scar tissue or fibroids. Sometimes you can have things like a non-receptive lining, an infection, anything that affects the lining's ability to attach the embryo or vice versa could cause an embryo not to implant. And then the last area is the most complex area. It's the most amazing area, but complex to understand. And what happens after an embryo attaches, sort of the activation of the trophoblasts involved in invading into the lining, laying down roots, and then forming a healthy placenta in an ongoing pregnancy. There we see a lot of autoimmune factors come into play, vascular factors come into play, and so we can have an issue with implantation there as well. So that's sort of my approach when we think about why implantation doesn't work. We investigate one of those three or all of those three areas.
And how often does implantation fail? Like, what is the sort of percentage of embryos that don't impact, or
Okay.
what's the percentage of patients that you see who would experience this?
So if we're talking about just implantation failure, single implantation, that's just the pregnancy rate, right? So
Mhm.
on average, an untested embryo in a healthy person has about a 40 to 50% chance. A genetically tested embryo has about a 60% chance. When we're talking about recurrent implantation failure, the number is really hard to come up with because of every study we use or every sort of database report we have, everybody uses different criteria to define implantation failure. There was a really, really nice paper published, I think just last year in our EBRMA group, Jersey counterpart, that looked at, I can't remember, something like 200,000 cases in their database. And they looked at chances to implant after sequential euploid embryo transfers. So trying to get at truly what is the incidence of implantation failure. So that paper showed nicely that if we transfer 5 euploid embryos sequentially without doing anything else, the chances of a pregnancy is about 98%. So estimating true recurrent implantation failure probably affects about 2% or less of the population. So it is rare. It's still extremely heartbreaking, however rare it is. And even though, we can sit from our perspective and say, after 5 embryo transfers, the chance of having a baby is still very, very high. I think people acknowledge or perceive implantation failure when they perceive it. So some people feel that they're in this category. Patients feel like they're in this category after 2 transfers sometimes, or sometimes people don't feel that way until 4 transfers. So the percentage of people who have it is difficult to estimate, is the short answer to the long question, or long answer to your short question.
That's thank you so much for that. And I think that helps, paint a real picture. Sometimes having a bit of data
Mhm.
can help settle things in your mind and make it make more sense. And especially when it's more, in those more challenging, or if you've been experiencing this on an ongoing basis. I am also now curious to know, is there's are there things that the data points to that you use with your patients that can help patients, or not help patients, but help reduce or increase, I guess, the incidence of implantation, or reduce the risk of it
Failure.
not implanting?
Yeah. So there's a lot of options out there. there are a lot of unproven ways that people approach this. Um, Typically, I try to keep it sort of standardized so that I have an approach. And my approach is when we do fail, when we are facing implantation failure, whether it's failure of, 3 or 4 untested embryos or 2 tested embryos, usually take a step back and look and see where we can do additional testing. And then depending on that testing, design a treatment plan. So my approach is sort of if they haven't had genetic screening themselves, because I approach it like I said, embryo attachment and then implantation. So the first thing we look at is embryo. If they haven't had genetic screening of embryo, we might consider that. We potentially could backtrack and look at genetics. Like we always take a history when we have patients asking about family history of genetic issues, but sometimes people are unaware. So we'll run a karyotype to see if maybe there's a structural.
We may have
um,
lost Oh, Dr. Sierra, you've just paused there for a moment.
can you hear me now?
Yeah, now I can. Now you're
Okay,
back. So the
sorry.
last thing I heard was about the genetics.
The genetics, right? So we take genetic history when we meet a patient, but sometimes people might have a genetic issue that they're not aware of. For instance, a structural chromosome rearrangement or polymorphism. So we do karyotypes to see if there's an issue there. I mentioned if they haven't done genetic testing, I would advise doing another IVF cycle and then looking at the genetics of the embryo so we know that's not a factor. We look at the lining, so updating imaging, sonohistogram, and then studying the lining a little bit. Here it gets a little controversial. So there are tools, there are commercial tests available to address attachment issues. So one of the ones I use frequently is looking at the microbiome. So the microbiome is a fascinating area of science that's just become very well explored, I'd say, in the last 5 years or so. And we understand the importance of the microbiome in our mouth, in our gut health, in the vaginal area. And we're just now learning about the impact of the microbiome in the lining of the uterus. So there's biologic plausibility to understand that we are living organisms with healthy balance of good and bad bacteria. And if there's an imbalance there, it could lead to malfunction of a system, such as implantation. So I do test for microbiome dysbiosis, we call it, and treat if it's found. The other test and potential treatment that people sort of were looking at, then it fell out of favor, and now we're thinking perhaps in a well-defined group with true implantation failure, we should look at the implantation window. So I spoke about how implantation isn't a one step process, it's a cascade of events. And that cascade of events takes place in a very defined biologic window. So there's a theory that if you're outside of that biologic window, if your body doesn't process hormones in a sort of textbook manner defining that window, perhaps there could be an implantation issue. So there's a test called endometrial receptivity assay, which again is commercially available. And like I said, it's a bit controversial because our studies don't indicate it's 100% beneficial. But again, it's not harmful to look at in terms of trying to figure out if there's an issue there. The other tests people are also considering is looking at when we talk about receptivity, the role of endometriosis. Again, there's commercial tests available to diagnose if that's a factor in the lining, and if so, or if there's a clinical suspicion of something like endometriosis, we can do a suppressive sort of protocol for a subsequent transfer. The other things that are important and that I do look at and counsel about are, extremes of body weight in situations of implantation failure because that has an impact. Other gynecologic conditions such as PCOS is also important. Sugar metabolism, very important in the receptivity of the lining. There could be a role in some cases for metformin. So it's not like I have a set box of tools that every single person with implantation failure is going to get. It just depends on clinical, their history, what they are presenting with and their story that helps define what testing to do. Um, and then there's this whole area of empiric treatment where you could probably have 10 REIs that'll have a different recipe or formula for what they call empiric, meaning potentially beneficial. If they believe there's biologic validity to a treatment, they might add it if it's not harmful. Things like low dose steroids, injectable blood thinners. There's protocols out there with antibiotics. There's protocols out there with antihistamines. So there's a lot of different ways to approach it, but a lot of it has to do with a patient's presentation, the physician's belief, what's tried previously, what's worked previously. But it's not an exact science for sure.
Mm.
There's no
No, that
100%
sounds like
right
it.
answer. Yeah.
Yeah, and it seems, that there's a multitude of factors that could
Mhm.
um, lead to this, and that there is some time that it may take in order to investigate, um, you know, and kind of pinpoint what a new sort of recipe or treatment protocol may be for a patient. Um, if you're a patient and you're a physician, so you're experiencing this, and your physician isn't sort of maybe exploring some of these options. I don't know that would be the case, but potentially. What are some questions that patients could ask in order to have their physician, consider either some of these tests, maybe it's a second opinion. What is your advice for people in that situation?
I think it's definitely a difficult place to be. Physicians sometimes rely on what's proven published,
Mhm.
and then we rely on our clinical guidelines. And for instance, our CFAS clinical guideline on recurrent implantation failure that we published a couple of years ago, if a physician was to follow that guideline step by step, there's not much that's proven beneficial. So that doctor wouldn't be wrong to say, I don't believe in these treatments. They've not been proven to be helpful, therefore we're not going to do them. But I think it's a matter of having a conversation, understanding, like a patient understanding that there isn't a right answer. There's not 100% right thing to do that your doctor's probably preventing you access to. But there's no harm in asking if you're curious about a certain test or a certain treatment, asking your doctor's opinion. You could get a second opinion if you'd like, but like I said, everybody's got a different way of approaching this. So it's a difficult space to navigate for sure. It's
Mhm.
not an easy place to be. Yeah.
Yeah, it sounds like it. And
Mhm.
um and it's sometimes hard from the patient on the sitting on the patient side, being unsure,
Mhm.
probably feeling frustrated. Of course, there's an emotional and financial
Mhm.
aspect to this. And at this point, you may have been in this for a really long time.
Mhm.
Um, and sometimes it feels a bit, when you're sitting in that patient chair, as great a relationship as you may have with your care provider, feeling unsure if you can ask a question, what you should ask. So it's good to at least be reassured that, um, that the clinical guidelines are there, and then it's going to depend. It doesn't mean your doctor isn't doing exactly as is written.
Mhm.
Um, it just is, that may be just the case.
Yeah. Yeah. And
Yeah.
and it's difficult. I mean, implantation failure, it's heartbreaking, especially even for the doctors to be part of that care team taking care of a patient that you see has worked so hard towards this goal and is encountering sort of repeated disappointment, even to the point where they're feeling almost anticipatory grief when another transfer is coming up. And it's really hard because there's so much uncertainty, and it's not just uncertainty in terms of why, but what to do next. And it's really difficult for physicians also to navigate in this space as well, because, like I said, we don't have any clear data, any clear guideline to say 100% this is the cause, this is the endpoint, and no guarantee of success. So it's a very difficult space to navigate, and I think it's just a matter of having a relationship with your doctor or your care provider where you can have open and honest discussions, understanding their perspective and them understanding your perspective. Um, and then, continuing to try is the biggest thing. I would hope that, in a situation where it is potentially not helpful to keep trying, for instance, someone who has a very thin lining secondary to scar tissue that can't be corrected. In that case, a physician might say, okay, we're at the point now where we should stop trying. But unless it's a completely futile situation, then there's always a little bit of hope. There's things we can try or or potentially give support to just keep trying and hope you'll get there.
Yeah. Yeah. And you're right. You think about the patients, and I appreciate so much, I've had so many conversations with so many physicians over the
Mhm,
years, and so many have said, when this doesn't work for whatever reason,
mhm,
um, how emotionally connected they feel and how devastated they are for their patients.
mhm.
And every time, a pregnancy doesn't occur,
Yeah,
after a treatment cycle. So, um, we know we're so fortunate in this country to have so many amazing doctors who are just so deeply passionate about helping people,
mhm,
um, achieve their dream of taking home a baby. So, um, we know it's not hard, not easy on the physician side and the entire care team, really,
yeah,
that we get so close to after all of those very, very early morning appointments.
yeah. It is hard, but I think that the the important thing is that there is hope. And I've been doing this long enough. I've had some really difficult cases and I've seen some really amazing stories. So if from my perspective, I can see that hope. I can see the reason to keep trying, but I understand it's hard from a patient's perspective that they might not. Like one of the cases that I'll share with you, long-term patient first came to me for recurrent pregnancy loss, and we had a tissue diagnosis that it was aneuploid, so it made sense to go through and do IVF and genetic testing. We made beautiful embryos, and then we started to try to transfer them, and it didn't work. I think we went through 6 euploid embryo transfers and nothing worked. And she finally gave up and she said, her sister was going to be the gestational carrier. So we set that up and it was successful. They took home a baby. And then when the baby was 2 years old, she came back and she said, I still got some euploid embryos. I just want to try again. And so she did, and she got pregnant and took home a baby. So
Wow.
it's just like, one of those things you kind of leave scratching your head. Well, why did it work now? And it didn't work those 6 or 7 times with no diagnosis. Um, and those are the kind of stories that leave us a little bit, you know, big question mark as to why and how. But at the same time, they give us a lot of hope and a lot of
Absolutely.
reassurance to keep trying and eye on the prize kind of thing. And I always say I can't see how you're going to get there with patients. Like, I'm not sure how we're going to get there to get you to take home your baby, but you will. You just have to take care of yourself along that journey, whatever the journey is. And I like that story. It's a good one.
That's a really good one.
Yeah.
Thank you for sharing that. I'm sure there are people sitting here who that will give hope to, for
Mhm.
certain. Thinking about just, um, are there things that patients can do at home? Either between cycles, while they're in a cycle, maybe they have exhausted all resources and they're with a physician who is sort of saying, like, we can't move forward. I don't know what's happening. Are there things, that patients can do on their own that can help, Is there any data on that? Is there anecdotal evidence? I'm just curious from giving people back a bit of, sometimes when you have something that to do, that can be helpful.
Yeah. No, there is. And I think that it's very common as people go through this to sort of feel like they are doing something wrong, right? Like people internalize the disappointment, they internalize the failure. Um, and understanding what we know about implantation, outside of obvious risk factors, there isn't much. Like it's not usually something you did or didn't, shoulda, coulda, woulda done differently. It just didn't happen because of some biologic process. And I think that's a really important message. The other thing is people worry about stress. Like that's a very common question. I think this is happening because I'm too stressed and maybe maybe there is something there. I'm not sure. We don't have the evidence to say, but anything you can do to make yourself feel better as you go through this journey is going to be of value. Um, there is a mind-body connection. We know that for sure in most of our biologic processes. So anything that settles your well-being or increases your well-being is going to be helpful. And that's where I think giving advice like ensuring sleep is regular. A lot of REIs, a lot of physicians suggest melatonin 3 milligrams at night as you're going through fertility treatment. It's a great antioxidant, but it also touches on the fact of how important sleep is. Sleep is like our biggest biologic regulator. It's anti-inflammatory. It settles cortisol levels, and all of those things are important if we consider how much of an immune modulated event implantation is. So making sure you're sleeping well, making sure we're eating healthily, exercising, being as healthy and full of life outside of the clinic as you possibly can. We're lucky at TRIO, we have Conceive Health on site. So they're our naturopathic team, and they work hand in hand with us in terms of advising around lifestyle. If there are BMI issues, they can help with weight loss. And then sometimes acupuncture. There is a little bit of data about acupuncture and fertility treatments, but again, not strong enough for us to prescribe it, for me to prescribe it universally. I always tell people when it comes to things like acupuncture or massage therapy, um, to try it. And if you feel better, if you feel regulated for having participated in it, then it's going to be a benefit and you can continue doing it. Mindfulness treatment, we know that there is some good evidence in fertility around that. And then sometimes in really, really difficult cases, trauma, it's almost traumatic going through recurrent implantation, or someone might have a very difficult history of loss and then implantation. So there could be a role for trauma-based cognitive care working with you hand in hand to kind of help go through this.
Yeah, that's really helpful.
Mm.
I find sometimes, again, this was part of my personal experience, that there are certain things that I wish when I was going through treatments, and I had treatments at different clinics, and that some things would have been recommended, especially how important taking care of my mental health was, and maybe seeking care from a reproductive mental health specialist or other options, not necessarily that they would have been prescriptive from my care team, but certainly having the conversations to say, hey, listen, these are also things that you may want to consider. And so I think that that's important information. And also, in the age of information sharing online, a lot of people are getting information, which is it's such a blessing in one way. So many more people are talking about their story, sharing their experiences. But at the same time, there's a lot of information, and sometimes it's hard to parse through what is a factual or relevant or could be helpful. So it's always nice when we have an expert on to help us navigate some of those things.
Yeah, and you touched on it. I think this concept, this internal locus of control concept is so very important. I've said it, and can't remember in your previous webinar, but
Mhm.
fertility is not like any other area in life. Everything else, 10,000 hours or whatever it was, 10,000 hours and you'll get your goal. With fertility, you can do everything right, especially in implantation, and still hit that brick wall. So it's different. You don't actually have control once we put that embryo in. Nobody has control anymore. So it's so important to take control of what you can take control of to a certain level where it's healthy. And I think that that's one of the things with so much information out there that sometimes people over overread or go down the rabbit hole of TikTok or Instagram reels or whatever and can get themselves very worked up. So, I talk about a buffer. So there's a psychological buffer in which we function. And part of that is being in control within that buffer, and things that put you outside of your buffer, like sometimes too much information, too much time spent on that information can lead to not functioning well in other areas. So again, everything with a grain of salt, and always keeping in mind what makes you feel good and doing the best you can do to have that happen while you're going through the fertility treatment.
Oh, that's incredible advice. Thank you. And just a reminder for everybody who's watching live, our chat is open. If you have specific questions for Dr. Sierra, please put them in the chat. Okay, after a failed cycle, what questions should patients feel empowered to ask their care team? And how can they advocate for themselves moving forward?
So I think it's really important for them to ask their care team from the physician and embryology perspective, how did it go? How did the embryo look? It's the most important factor if a pregnancy is going to be or not be is actually the embryo. So, did it survive the thaw? Did it expand? Was there any technical issues with the embryo transfer? That kind of thing is important to know because again, it sort of, if there was an embryonic issue, people will feel a little bit better about trying again, right? It is really truly out of their control. Um, Looking at the cycle, was there anything about their lining that was worrisome, any risk factors? And then, going into what other testing and when to have that conversation actually depends on both. It depends on the physician and it depends on the patient. So most of the time, we know as wonderful IVF is, one IVF cycle doesn't always make a baby. If we look globally at our data, it's 1.6 cycles on average for somebody young and healthy to take home a baby with IVF. So going into an embryo transfer, I think you have to have some idea that we're doing everything we can do, but it might not work. We take a deep breath and we try again. It's when we fail multiple transfers that you want to take a break and see if there's something else going on, and deciding when to take a break and have that conversation with your doctor is up to you and up to the doctor. So you'll both decide when it's right. Because I've had patients who fail, who have 10 untested embryos, right? They haven't been genetically screened, and we know 10 embryos does not make 10 babies. It would be wonderful if it did. So we already know there's going to be some trial and error. So we don't necessarily worry about implantation failure after the first, if it takes 2 or 3 transfers to get there. But again, I deal with the patient sitting in front of me. So if that patient's very upset or very stressed or very concerned that there's something going on, or has a feeling that they didn't feel good after the transfer, we take that into account, and whether they want to get an implantation failure workup after 2 transfers or 4 transfers, we sort of decide together.
Mm, that's really important. And I think that's just, something to help people digest. Um, especially those who are sitting here right now thinking they may be right in the middle of this,
Mhm.
or have recently gone through something like this, to just help them sort of put it into perspective.
Mhm.
I have a quick question because we've been doing a lot of talk about obviously the embryo, even uterine lining, but the embryo comes from an egg and a sperm. And I'm curious to know how much impact the sperm and or the person who the sperm came from, whether that's their partner or donor, is there an impact on implantation failure from the sperm?
Definitely, there could be an impact. So definitely, if there's a genetic issue like a structural chromosome rearrangement that the male is carrying, it can lead to implantation issues. Um, the other thing is that there is something DNA fragmentation, so the integrity of the sperm can reflect the ability of that sperm to be able to facilitate healthy cell divisions, carry on, and make it a healthy pregnancy. We know from the um, recurrent pregnancy loss data that DNA fragmentation is associated with recurrent loss, and by the same token, potentially could affect implantation. Um, the other thing is there's a whole metabolism of an embryo that's so important, and sort of the energy of the embryo. So the genetics of the egg determine most of the time the genetics of the embryo and the ability for it to carry on. But once we have a genetically normal embryo, I mentioned there's still hundreds of thousands of cell divisions. There's a lot of energy, there's a lot of metabolic features of the embryo that are needed to take home a baby. And that's where sperm health and factors can come to play as well.
I think it's so important to remind
Mhm.
ourselves that there are two cells here coming from two different people. In terms of DNA fragmentation for the sperm
Mhm.
and thinking about the sperm quality,
Mhm.
what are things that the male partner or the person whose sperm this belongs to, what are some things that they can do to increase, because sperm, unlike the egg,
Mhm.
sperm regenerate every, I don't know what the day is, 100 days or something, is it?
Yeah.
Um,
Use sperm every 72 hours and then the full life cycle about 100 days. Yeah.
so there are things that the male partner can do
Mhm.
are there things that the male partner can do to improve sperm if this is something that has become an issue?
Yeah, definitely. So just like lifestyle is important for egg quality and for reproductive health for females, for males, the same. So, maintaining a healthy body weight, avoiding obvious risk factors like excessive alcohol use, smoking, terrible impact on the sperm. Recreational drugs, if we're smoking cannabis and things like that, it can have a similar dose dependent impact on the sperm. Lifestyle factors are important as well. So lifestyle outside of toxins, like things like regular exercise are important, but what kind of exercise we have to also be mindful. So where sperm is made, it's outside of the core body and therefore lower temperature than the core body temperature in men. So anything that increases the temperature in that area on an ongoing basis will impact the sperm. So, sitting for long periods of time, riding bikes, wearing tight underwear, even putting cell phones in the front pocket, laptop on your laps, all those things, when you're trying to conceive, a man should be aware of those things and the impact on sperm and the impact on a baby, chances for a baby. Yeah.
Oh, thank you. I think that those are really important and helpful. Just, again, it comes back to the more you know and the more information you have, you can
Mhm.
make more informed decisions, but also reminding people that there are things that you can do external to this that may make you that help you feel like, okay, I've done everything I can do in order to ensure this is that we maximize our chances for success. We have a couple of questions coming in the chat, and I'd love to ask some of those. To what extent does maternal age influence implantation rates and overall success?
Maternal age, it
Hmm.
definitely makes an impact. So, maternal age is the biggest risk factor for embryo health and genetics. The number one reason an embryo is not going to implant is if it's genetically abnormal or aneuploid. And as we get older, the chances of aneuploid embryos increases, unfortunately. It's not like we hit 35 and it's a brick wall, but there's a gradual decline in your ability to make healthy embryos over age 35. And that's why we say, like, when people are planning families, try to give the advice young that you have a 90% chance of taking home the family of your dreams if you complete before 35. It's not always possible, especially in our generation. So if you are approaching fertility treatments and you have had a history of implantation failure and you've not done genetic testing, it might be something for you to think about.
Thank you. Oh, the questions are coming in now. Is it more common for the transfer to fail or not implant at all, or implant but then not be successful, so not continue to develop?
Mhm.
Are there different reasons for those two scenarios to fail, or are they the same?
So I'm not sure in the second scenario if they're talking about chemical losses or
Mm,
if,
it says, yeah, I'm not sure either.
yeah,
It says to
because
implant but not be successful.
we,
So,
so that the end goal is a negative pregnancy test, we don't really know when the failure happened. Like, did it happen at the embryo stage before it attached? Did it happen after attachment when it was trying to implant it? It's hard to know. If you're talking about chemical losses, usually those really early pregnancy losses are due to similar reasons as implantation and mostly embryonic, but it could be something else in the lining as well.
okay. Um, okay, this is another question. I have an embryo transfer in 2 days, a
Mhm.
day 5 for AB. I haven't really been eating right and exercising. Is it too late?
No, I don't know your full history, but if you're generally healthy, normal body weight, balanced diet, I think you should be fine. I don't think there's any prescriptive diet that is going to be helpful or not. And exercising, again, as long as you're active, even after embryo transfer, you can still be active and healthy. I don't think you should feel badly about either of those things leading up to an embryo transfer.
Yeah, that's really sound advice.
Yeah.
If the embryos are from age 30 and you are transferring at age 38, does this maternal age affect things as much?
So, good question. And it's kind of a common question, but actually, no. The uterus is the most amazing little incubator that doesn't care about age. We can manipulate a lining at any age, which is why you hear crazy stories about twin pregnancies in 70 or whatever it is. So, age doesn't impact the ability to implant or carry a pregnancy. The age of the embryos is by far more important. Assuming that, you've been worked up and you have a normal lining and everything else is healthy and well.
Fantastic. That's good news. There's been some discussion internationally about ovarian PRP helping to improve egg health. Is this something that's happening in Canada? And is there any good data on this?
So when ovarian PRP first hit the scene, it was very exciting. But
Can we tell everybody what ovarian PRP is? Just so,
plasma-rich protein infusions that we think work to help the metabolism or reverse the metabolism of older eggs. Um, and so people were injecting it into the ovary, people were injecting it into the lining for thin lining. But I have not seen anything published to show it helpful. I've had a few patients because we don't offer it. I don't know anyone offering it in Canada. But I have a few patients who went internationally to do it and did not have any success. Dr. Casper, who we're lucky enough to work with, did a study on early early menopause, so premature ovarian failure, and ovarian PRP. He's collecting some data now, but again, so far we've not seen any positive outcomes. So I'm not sure. There might be benefit to thin lining and PRP, but I don't think it's the answer to improve egg health or reverse aging, unfortunately.
thank you. Is a subchorionic hematoma related to implantation failure?
No. not that I'm aware of. And it's not really related to pregnancy loss either. Up to 70% of pregnancies have subchorionic hematomas. It's in some cases just how implantation happens, almost like an internal bruise almost. It has to do with the balance between bleeding and clotting, how has implantations happening. But again, I haven't seen any studies that have shown it to be a reason or a cause so far.
Thank you for that one. Can treating chronic endometriosis improve success rates? Can implantation work with chronic endometriosis?
So those are also good questions. So that's sort of an area that, again, now we're collecting data as some biopsy tools are commercially available and people are looking at this more. It's long been suspected in the area of recurrent pregnancy loss to cause an impact. And with respect to implantation failure, there's a small study that was published in I believe Spain, Moreno's group initially that showed diagnosing and treating endometritis can improve take-home baby rates in patients who had implantation failure previously, but small numbers. So in the published literature, we can't say 100% does it or doesn't. However, on a case-by-case basis, if a patient's presenting with risk factors for chronic endometritis, such as multiple surgeries or DNCs or losses, retained products, then yes, I think it can help if we diagnose and treat it. Can implantation work with chronic endometritis? I'm not sure. I don't think we know. And there's different degrees. Like the way we used to diagnose it was the presence of plasma cells that are sort of inflammatory markers in the lining. And you could have one per high power field, or you could have 10 per high power field. And no one's looked to see if there's a difference in take home baby rates, if there's just a little bit or a lot. So I don't know the answer to that question. But again, if there's risk factors for it and we find it at any degree, I would definitely treat.
Okay, thank you. If an antibiotic has been taken 3 to 4 months before an FET, do you have any advice for optimizing the microbiome before the FET? This person said they've already taken a vaginal probiotic and FH relatively recently. Sorry, my screen, I need to get better glasses. The letters on my screen are really small.
That's okay. I think if you've taken an antibiotics 3 to 4 months before FET, it's probably out of your system, but you've done a good job with the probiotics. So even if we do believe there was an offset in the microbiome, you've corrected it, and I don't think you need to do anything further other than eat a healthy, balanced diet.
Perfect. You had mentioned the egg is overall responsible for embryo health. Does something happen day 3 or 4 of embryo development with the sperm where a patient's REI can tell if maybe a sperm or DNA fragmentation issue post embryo development? Does that make sense?
Yeah,
Is that
that's a
right?
good question. And the answer is I wish we could. I wish we knew for sure when embryos don't progress beyond cleavage to blastocyst, if it's sperm or egg. I think it's both. I think again, when we think of an embryo on day 3, it's 6 to 8 cells. And then over the next 48 or 72 hours, there's this amazing process where there's an explosion of cell division, and it goes from being something we can count to being so cellular we can no longer count, and we look at the form. And in that period, like I said, there's a lot of energy, and the energy has to come from the cell, and that's where I think it's most likely egg and sperm together. But there's no way for us to know which or both or none is the issue.
Okay. All right. Does azithromycin, did I say that properly, negatively or positively impact implantation?
It doesn't make a difference. That's just an antibiotic. It shouldn't make a difference.
Okay. All right, we've got a couple more questions before we wrap up. I had a failed transfer in December and found the prometrium plus irritating. Oh, maybe that's what it means. Very, very irritating. I felt like I had a yeast infection at times, but it was difficult to tease out from the prometrium discharge itself. Can I take a vaginal or PO probiotic to help alleviate this with another transfer?
I think there's no harm in taking a vaginal or an oral probiotic. Again, unless you have a true diagnosis, it's hard to say what you typically need or don't need. But when we're thinking empirically, do no harm, there's no harm to trying and seeing if it alleviates your symptoms. The other thing is there's many different ways you can get progesterone. So if you had a reaction to prometrium, there's different ways, other methods to treat the lining, different forms of progesterone that you might want to try.
Great. There are lots of clinics in Canada that are making baby aspirin a part of an FET protocol for everyone. What are your thoughts on this?
So that's another empiric treatment. Again, there's not a lot of harm in using baby aspirin. Biologically, maybe it does increase blood flow, so it could be a benefit. It's probably a doctor by doctor decision as opposed to a whole clinic. The other thing is now we have good data from the our obstetric colleagues to suggest that every woman conceiving and delivering over 40 should be on low-dose aspirin to reduce the risk of blood pressure issues, placental issues. So if I'm writing a protocol on someone who's 40 or higher, I will include aspirin. But I don't think like I said, I don't think there's any harm.
Fantastic. All right, we've got time for just one more question. This one is says, I was late to the session, so I may have missed this part. I was wondering if there are any tests you recommend or that we should advocate for after a recurring implantation failure.
So again, it just depends on what you have already done, and what your doctor feels important. But we talked about embryo tests, we talked about lining tests, and then we talked about autoimmune testing for the implantation part of it. So there's 3 separate areas, 3 separate processes with implantation that you could potentially investigate.
Yeah, and we're going to send the recording out to this after to anybody who is registered. So you'll be able to go back and watch the first part of the session to get that information. We went into depth on a couple of them, so I think it's really important. And even if if you were here live watching, it's, if you feel you've missed something, you'll be able to go back and watch that. Dr. Sierra, this was very informative. I took a ton of notes for myself. I've learned a few things. There's lots of thank yous coming in the chat for your time. So we appreciate you so much. And, we know that you're in the middle of a busy clinical practice and just appreciate you carving out some time to have this conversation with us. In closing, is there anything else that we missed or that you want to hit on before we end the session?
No, I just want to thank you for addressing this really important topic. And I just want to say, it's a really hard place to be, and your doctor's right there with you. And I think that always maintain hope. And like I said, where there's a will, there's a way. It's just a matter of how you're going to get there. We can't see, but yeah, hang in there.
Yeah. Thank you. Thank you so much. And for everybody who joined us, thank you for being here today. Thank you for your time and your interest in this topic. It allows us to continue to bring these types of educational sessions to you completely for free. A reminder that Fertility Matters Canada is a registered Canadian charity. And if you have the means or if you feel so inclined that you can make a donation to our charity by visiting fertilitymatters.ca. A huge thank you again to our sponsors, First Response, for their support of our education and our support group programs. And Dr. Sierra, thank you again for your time. I look forward to continuing to work together over the next year.
Sounds good.
Thank you, everybody.
Thank you so much. Bye.
Bye.